A warm welcome and very good evening to all dear participants. The resource person of today's session, Dr. Indranil Saha sir, and chairperson of today's session, Professor Dr. Satya Dayal Sharma sir. Again, welcome to all of the participants and our respected dignitaries, respected resource person and chairperson of today's session. Now, I would like to introduce today's resource person of the session, Dr. Indranil Saha sir. Sir is currently serving as a scientist E in the Center of Non-Communicable Disease, ICMR, New Delhi. Sir has been served as assistant professor at Burdwan Medical College and before that as a associate professor at IQCT Medical College, Durgapur. Sir also served as a professor at IQCT Medical College, Durgapur. He is a member of Medical Education Unit, MEU, Curriculum Committee of IQCT Medical College. Sir is a fellow of Indian Public Health Association and has just as a best ICMR STS project in 2016 and guide of many PhD theses. Now, I would like to invite Sir to lead today's session on Interventional Study Design and its measure. Please, Sir, welcome, Sir.
Okay, okay. Thank you, Mr. Amit. And with permission from our respected chairperson, sir, can I start the session?
Dr. Satyamangal, Sir, please unmute yourself.
Yes, please start.
Okay, okay. Thank you, sir. Thank you. Is my slide visible to all of you?
Yes, sir, visible. Make it in slideshow mode. So it will be maximized.
Is this okay?
Yes, sir. Perfect, sir. Perfect, sir. Thank you, sir.
Okay. So good evening, participants, and with permission of our respected chairperson, sir, and coordinator, Mr. Amit Kumar, I am starting today's session. So my today's session is on interventional study design and its measure. So just going on to the experimental studies, I'm just briefing you up the different types of study design, epidemiological study design, right? So epidemiological study design, if you see, it is broadly classified into two types. One is the observational studies and second one is the experimental studies. Again, what is the difference between the observational studies? In observational studies, we allow the nature to take its own course. Here, investigator does not intervene. So here, investigator is just mere spectator. He just observes what is happening and going on in two or three different groups, and accordingly does the analysis and interpret. But in experimental studies, active attempt is made to change the disease determinant or progress of the disease. So in experimental studies or intervention studies, here the researcher is not only spectator, he is actively giving some drug or actively withdrawing something just to make something happen. So this is a basic difference between the observational studies and the experimental studies. Again, observational studies are divided into two types. One is the descriptive studies, where we describe the occurrence of disease in terms of time, place, and person. And in case of analytical studies, we simply analyze the relationship between the health status and the different variables. This is the different types of observational studies. And in experimental studies, if you see, there are three types of experimental studies that we will go on. So in experimental studies, what I have already said you that here the researcher is not only spectator, he is actively intervening. So active attempt to change a disease determinant such as an exposure or a behavior or the progress of a disease through treatment. Say for one example, we are treating one group with new drug and treating other group with the available drug, and we are interested to see the outcome of the things. Next, so example testing of a new treatment on a selected group of patients. So from outside, we are administering something. We are giving some intervention. This is the beauty of the experimental or intervention studies. Broadly, experimental studies, these are classified into two types. One is without control group and with control group. So what does it mean without control group? Without control group means the study population, they are in a single group, and we don't have any other group just to compare with that single group, right? So one group is there, and in that single group one intervention is given, and at the end or after some time the effect of intervention is seen and measured. That is without control group. Again, experimental study, it might be with the control group. This is superior type of study. So this with control group, they are classified into two types. One is the randomized control trial and one is the non-randomized control trial. So we will discuss in details. So this is the basic structure of the experimental study. So without control group, so here means only one group is present, and with control group means two or more groups is present. How we divide the two groups, in on that basis we name it either randomized control trial or non-randomized control trial. So without control study, what I told you, before and after study design. What does it mean? So in a population, suppose we have given some intervention, and after that intervention, we are interested to see what is the outcome of the disease, whether the disease incidence has occurred, it has increased, or disease incidence has decreased, right? So this is the thing of the without control group. The events took place prior to the use of the new protective procedure and used as a standard composite. Example, you see one of the classical example is the prevention of scurvy among the sailors. So here there was no control group, only single group was there, and in that single group some intervention was given, and in that after that giving that intervention we were interested to measure the outcome of the disease, right? So this is without control group. And next one, just for example, you see, for categorical one outcome, say for example one group is present. This is, I'm talking about one single group where one particular outcome is measured. Say for example today's participants, so many participants are there in this online session. Now suppose I have administered one questionnaire. In that questionnaire I have seen that how many of the participants they are having anxiety and how many of the participants they don't have any anxiety, right? So total online participants, now I have measured by using one questionnaire. We have measured how many of you have anxiety, how many of you don't have anxiety. Now I'm giving some intervention. Say for example this session is a counseling session. Now after my session will be off, my session will be closed, again the same questionnaire will be used upon you just to measure the outcome again, right? So this is the thing will be like this thing. You see, pre-anxiety, so pre-test how many of you have anxiety, and in post-test how many of you have anxiety again. So in that way this is one of the classical example of without control group. Here commonly we use one statistics that is known as the McNamara chi-square test. So single group before intervention and after intervention, when we are interested to compare the categorical outcome. Say for example what I told you, how many of you have present anxiety was present, how many of you was anxiety was present after the intervention, right? So this is an example of the categorical one outcome. So you see this pair, you see this is basically what I have written. This is an hypothetical example. Say for example in 54, what does 54 means? 54 means that this 54 pairs, actually 54 means 54 pairs, that is how many participants are present in this cell. It is 54 into 2. So participants are 54 but observations are twice. Why observations are twice? Because one observation was taken before intervention, that is before this counseling session, and one observation from the same participants after the counseling session. So in that way you see 54 is there. So that means 54 subjects, they have anxiety prior to the intervention and they still have the anxiety after the intervention. Now this is also 78. You see they don't have anxiety before intervention, and after intervention they don't have anxiety. So these pair are known as the concordant pair. Now you see these two cells, this 36 means this 36 observations, persons, they had anxiety previously, but post test they don't have anxiety. Again, if you see out of the 62, they don't have anxiety before intervention, but they develop anxiety after the intervention. So these two pairs are known as the discordant pair. So this one statistical test is used in this classical situation where one single group without any comparison is compared before an intervention and after an intervention. The test is known as the McNamara chi-square test. Now, coming to the proper experimental studies or intervention studies with control group. Now, previously what I have talked, these are all without control group. Now, I'm talking about the with control group. So, experimental studies, these can be further classified into 4 different types. One is the randomized control trials, also known as the clinical trials. You see, this is very important. Here, individuals are the unit of study. The individuals are the unit of study. Now, in cluster randomized trial, groups are the unit of study, right? So, in my discussion, that will be much more clear once we carry on the discussion. In field trial, healthy people are the unit of study, and in community trial, communities are the unit of study. So, these are the very important, tricky things that you have to remember. Now, from the name intervention study, it is clear that in one group, when we talking about the with comparison group, so that indicates in one group intervention is given and in another group intervention is not given. So you see, this is a very critical situation. So I have taken one group and I have divided the entire group into two different groups. So one group will have the intervention and one group will don't have the intervention. So you see, there is a very much ethical considerations are there. Say for example, I have selected 50 participants from one hospital and I have divided the 50 participants into two groups comprising of 25 persons each. Now in one group I am giving one intervention and in another group I am not giving any intervention. So what does it mean? So the other group, those who are not getting any intervention, they might be angry, they might raise one issue. You are doing one experimentation or research for your own interest. We are not getting any benefit out of it. So there is a very much ethical considerations are there. So another important thing you have to remember that no patient should be denied appropriate treatment, and it must be acceptable in the light of current knowledge. So you see, this is very important. So no patient should be denied. Each and every patient will get the opportunity to receive the latest treatment and the best of the treatment. And what is the best treatment at the present date? And informed written consent is must. As you know, whatever be the intervention studies or the descriptive studies or the analytical studies, informed written consent is must. Without informed written consent, we cannot initiate data collection from each and every person. Now, what is field trial? I told you that field trial is applicable for the healthy people. So what happens, these trials involve people who are disease free. So please remember, in the field trial, all the people, those who are involved in the trial, all of them, they are not suffering from any disease. They are absolutely disease free. But you can ask me one question, sir, since they are disease free, then what is the justification of including them in the trial? But I can argue that in spite of the fact that they are disease free, but they are presumed to be at risk of developing the disease. That is a very important thing. So what happened, you see, data collection done at the field level. Field level means at the community level. So what does it mean? That means those who are not coming to the hospital or those who are not admitted in the hospital. That is why it is written at is non-institutionalized people in the general population. Next, so example, so Salk vaccine for the prevention of poliomyelitis involved over 1 million children, right? So this is very important. So whenever vaccine trials are given, so this is you can treat it as a field trial. So one of the largest field trial example is the Salk vaccine that is given for the prevention of the poliomyelitis that involved over 1 million children. those 1 million children were disease free, but they were at high risk of contracting the disease. That is why they were given this Salk vaccine. So measurement, another example is the measurement of blood lead level in children has shown the protection provided by elimination of lead paint in the home environment. That is not required, but that is important. Please remember, Salk vaccine is the polio vaccine that was given by the injection. So that vaccine was given to the disease-free children, and after that they were followed up that how many of them they developed poliomyelitis and how many of them they did not develop poliomyelitis. Clear? This is a classical example of the field trial. Now you see this is an schematic flowchart. The population is there. Now from that population we have identified the eligible population. Some population we have identified and we have excluded them from the study. So we will not include them in the study. Now that eligible population, they are basically randomized. I will tell you the term, I will come to the term later on. Randomization is the statistical procedure by means of which the entire groups are divided into two or more groups by one probability loss. So this is the randomization. So it is a statistical procedure by means of which the persons are allocated into two or more groups. So in randomization, you see this group they receive the Salk vaccine for poliomyelitis, and the other group they did not receive any such vaccine. After that, all the two groups, the members of all the two groups, they were followed up for pretty long time. After that, after a certain period of time, say for example 1 year or 5 year time, they were followed up that how many of them they developed the disease and how many of them they did not develop the disease. Again in the other group as well, how many of them they developed the disease and how many of them they did not develop the disease. If I see diseased people are more in the groups where they did not receive any vaccine, and the disease is much less in the group where the children receive the vaccine, then we can say yes, the vaccine has some good effectiveness. It worked in the community level. So this is how we interpret the field level. Am I clear to all of you? Hello, am I clear to all of you?
Please respond in chat box or using thumb.
Okay, great. So if you have any question, please write it down so that at the end of the session we can discuss it, right? Next is the community intervention trial. Second type of trial is the community intervention trial. As I mentioned you earlier, in field trial, healthy people are the unit of study. But in community intervention trial, here the entire communities are the field of study. So treatment groups are communities rather than the individual. What I said in the previous slide, in the field trial, healthy people, those who are healthy, they are disease free but presumed to be at developing at risk. They were the unit. But here you see the treatment groups are communities rather than the individuals. So this community intervention trial is particularly appropriate for the disease influenced by the social condition and for which prevention efforts a target group behavior. Say for example, in some of the communities, I have seen that tobacco consumption is much higher. In some communities, alcohol consumption is much higher. These are the factors, these are influenced by the social condition where one particular individual should not be targeted. Rather, the entire group will be targeted, isn't it? So this is the known as the target group behavior. So in those critical situations, these community intervention trials are carried out. So another example is the cardiovascular disease. Cardiovascular disease is another good example where some community intervention trials have been conducted. So you see, this is the flowchart of community intervention trial. In one of the study, you see 32 communities in two districts assessed for eligibility. So two districts were selected, one from one state. Say for example, from Uttar Pradesh, two district we have selected, and from that two district we have selected 32 communities. So what does it mean communities? So one community might be representative of one gram panchayat or one cluster, something like this thing, or one village like this thing. So in that way, you have to define the communities. So communities might be villages, communities might be consisting of a group of villages covering one gram panchayat, something like this thing. So from the two districts, we have identified 32 communities, and these 32 communities, it has been randomized. So what does it mean, randomization? Randomization means allocation of the entire group into two different groups. So now you see the 32 communities we have randomized. We have placed 12 communities in one group and another 20 communities in other group. So 12 communities assigned to intervention group. So total population you see something like this thing. And in 20 communities assigned to control group. So total population is this much. So 12 communities, they were followed up and 159 smear positive tuberculosis patient was detected. And in the other community, you see 221 smear positive tuberculosis cases was detected. And now you see in this one group at the end, 81% patient they completed treatment, only 16% was defaulter, only 3% died. But you see in the other group, you see the outcome is not so good compared to the first group. You don't have to remember the percentage. You don't have to remember the percentage, but only remember this thing, that in these 12 communities, one specific intervention was given, and in the other group 20 communities, that intervention was not given. But at the end, you see 81% was successfully completed, but here only 75% completed. 16% defaulter, it is much less, but here the defaulter rate is much higher, 22%. And in both the cases, 3% were died. Right. So this is the structure of the community trial. Now I am coming to the randomized control trial. Right. So this is a picture of a randomized control trial. You see where I have shown you the picture of 4 different patients. So please remember, who are the participants of randomized control trial? In randomized control trial, all of them are patients that is suffering from one particular disease. That I did not tell you in the field trial, that I did not tell you in the community trial as well. Clear? So in community trial, it might be like this thing, somebody they were suffering from disease or some of them not be suffering from the disease. But in field trial, all of them are absolutely healthy. But in randomized control trial, all the participants are diseased participants. All of them, they are suffering from disease. In this example, I have shown you 4 different patients. All of them, they are suffering from hypertension. All of them, they are suffering from high blood pressure. The first patient you see, the blood pressure is going on, checking is going on. The second person you see, the patient is having the headache. The third person you see, he is having the reeling of head, that's the vertigo. And the fourth patient you see, the gentleman, he is suffering from the precordial chest pain. So what I mean to say, all of them, they are suffering from the disease. All of them, they are suffering from the hypertension. Now what I am doing, you see it. Now I am dividing some of the patients in one group, and I have divided some of the patients in other group. So is this clear? So the entire group, I have shown you 4 patients. Now think hypothetically that there are 100 such patients. Now these 100 such patients, I have divided the 50 patients in one group and 50 patients the other group. How did I distribute? This process is known as the randomization. What is randomization? I have already told you. Randomization is a statistical procedure by means of which the group is classified into 2 groups so that the 2 groups becomes comparable to each other. This is the basic intention behind randomization, so that you can compare between 2 groups. So like can be compared with the like. So you see, this is the randomization procedure. Say for example, 100 patients, they are divided into 2 groups. Each group is having 50 patients. The process is randomization. Now you see, in this new group, in this group, say for example, one new drug has been administered. The new drug is the telmisartan. And the other group, you see, say for example, the old drug amlodipine is given. So please remember, in one group, each of the patients, they will receive telmisartan tablet, one tablet once daily. But in other group, you see, each and every patient, they will get one tablet amlodipine once daily. Now, should I give the tablets in that fashion? No, we will give it in that way. Is it clear? You see the strip. Now, by looking into the strip, you won't be able to differentiate which one containing telmisartan, which one containing amlodipine. So in that way, a drug or something will be, the intervention will be administered. So now you see the strip, the color, the size, and if someone consumes the tablet, the taste, everything will be same. Everything will be same. So this is the way to blind them, to make the participant blind, so that they won't be able to understand in which group they belong. Now you see, each of them will continue to take this tablet for 6 months, and each patient of this group, they will continue to take this tablet for one tablet once daily for 6 months. Then after 6 months, we will follow them up and the assessment will be done. Say for example, at the very beginning, after randomization was done, we will measure the blood pressure and we will calculate the mean blood pressure as well in this group as well as in this group. Now after 6 months, after they have received one tablet once daily for 6 months in both the groups, after 6 months we will again measure their blood pressure, and separately we will calculate the mean blood pressure of this group and also the mean blood pressure of this group. If I see the mean blood pressure has reduced significantly or substantially from the previous one, whatever with the drug, then only we can say yes, telmisartan is better than the amlodipine, or say for example a new molecule is better than the other molecule. Am I clear? So this is the basic structure of the randomized control trial. So two groups randomization, one tablet will be given, two different tablets, but they won't be able to identify, and they will take the tablet for the 6 months, and then after 6 months we will follow them up and the assessment will be made and the comparison will be done. So this is the basic structure of the randomized control trial. So you see, I have already told you, study population is randomly allocated into groups called the treatment groups and the control groups. Patients are allocated randomly, that is by chance, for comparability. I have already told you the justification. So results are assessed by comparing the outcome in the two groups. In whatever group we will see the decline is more, then only we can say yes, in that particular group, that particular intervention worked well compared to the other group. So I've already told you that this is the justification of the randomization to make them comparable. So now if you see, there are basically three types of trial and three types of designs of randomized control trial. So different three types of trial we talk about. Basically, one is the therapeutic trial, where treatment of a disease is evaluated. What I showed you just now in the slides, one treatment was given. And in intervention trial, an intervention is evaluated in a person with high risk of developing a disease. So in intervention trial, some intervention is done in a person with high risk of developing a disease. Say for example, those who are overweight, and we are giving some exercise so that the person will lose some weight. So intervention is given in a high risk of developing a disease. And third one is the prevention trial. Prevention trial is basically efficacy of a preventive measure is evaluated. It might be a vaccine as well, right? So these are the basically three different types of trial, and there are three different types of designs. One is the clinical trial. Clinical trial means one or more health related interventions are evaluated, so that you see the safety and dosage of a new drug or new intervention or new vaccine, what is being generated, that is by the clinical trial. Second one is the factorial trial, tests more than one hypothesis with multi-arm. Say for example, I have told you two different arms. Say for example, I am having four different arms. In one arm, I am giving something, say for example, one tablet, and in second arm, I am giving the same tablet and one syrup. And in third arm, I am giving another separate tablet, and fourth term I am giving that tablet and another syrup. So these are basically the factorial trial where more than one hypothesis, these are tested with multi arms, right? So this is factorial trial. And the last one is the crossover trial. Crossover trial means initially what I told you, after randomization we are having, say for example, we are having two groups. These two groups, they will get one intervention for 6 months. Then after that 6 months, the intervention will be stopped for 1 month or something for some period. And then the group that belong to intervention group will come to the control group, and the control group previously, they will come to the intervention group. So the one crossing is happened. This is known as the crossover trial, where participants act as their own control. Clear? Next, in the RCT, you see classical RCT, what is basically done in the controlled environment, in the lab setting, where everything is done and each and every participants, they have been recruited for the trial. This is basically known as the classical randomized control trial, which is done in a very much lab setup and in a controlled environment. So we see the efficacy. But what we do sometimes, it is the pragmatic randomized control trial. So what is done in the normal environment or in a hospital setting or in a normal practice. So these are known as the pragmatic, that is in the nature of what is going on and we are giving treatment. So this is known as the effectiveness. Say for example, I'm doing one clinical trial in one from and we are recruiting the patients from the hospitals, and from the hospitals we are grouping them into two groups, and in one group of patients they are receiving one particular intervention, the other group they are not receiving any particular intervention. So in that way, this is the classical situation, ground situations. So this is known as the pragmatic trial. So where we see the basically when the endpoint is seen in a very controlled environment, we term it as an efficacy, and when it is done in a normal environment, in the setting, hospital setting or the community setting, then we call it as an effectiveness. I have told you it is in statistical procedure. The basic thing so is that the intervention group and the comparison group, they become comparable to each other. So another important point, it is an attempt to eliminate the bias and allow for the comparability. So I am telling you the term repeatedly. So randomization, the basic intention behind randomization, so that one group can be readily compared with the other group. So in that way we eliminate such bias, and we allow and we that comparability is allowed, and we can compare, and in that after comparison we can say yes, this group is doing well and this group is not doing well. So at last we can say yes, intervention has worked or intervention did not work. So by randomization we eliminate bias. I have told you, we basically eliminate the selection bias. This last point is also very important. So randomization is done only after the participant has entered the study. Sometimes we have seen that somebody is telling, I will do one trial, I will randomize the patients into two groups or three groups. After that, I will see how many of them are eligible, and some of them will be finally recruited and some of them will not be recruited. This is wrong. So please remember, this is wrong. So randomize. So first, after you have identified the group, you select each and everybody, because all in RCT all of them are patients, all of them are suffering from some of the disease. You select from them how many of them are eligible and how many of them they are not giving consent and not eligible at the same time to participate in your study. In that way you exclude, and the remaining people, those who have given consent and those who matches your selection criteria, inclusion criteria. Now you randomize into two groups or three groups. So randomization is done only after the participant has entered the study. There are different methods of randomization. These are some of the methods I have listed here. One is the simple randomization, block randomization, stratified randomization, and unequal randomization. In some randomization, it happens that equal number of participants are there in two groups. Say, for example, 50 participants in one group, 50 participants in other group. But it might so happen that in one group there are 40 participants and there are 60 participants in the other group. So unequal randomization, it also might occur. So these are the different methods that you have to remember. But nowadays the researcher, they mostly rely on the randomized number that is generated by the computer generated random number table they generate, and accordingly they distribute the patients into intervention group or the control group. So these are some of the other methods, but most commonly whatever we do now, it is the computer generated random number method. Say for example, I am telling you all of the patients are coming, we are numbering them 1 2 3 4 5. So every third patient or this thing, even odd, in that way also we can distribute them in the intervention group or the control group. There might be different types of bias in the randomized control trial, that is known as the subjective bias. Subjective bias, when it can arise, it arises only when the participants, they become aware in which group they belong. So as a result that the participant should not know in which group they belong. But if they know previously, yes, I'm in the intervention group and I'm getting the new drug, and in the other group they have come to know, yes, we are receiving the old drug, so they are naturally not so happy. So subjective bias might occur after the end of the study, after 6 months. If you ask them, how did you feel, what about your headache, what about your reeling of head, what about your chest pain, if they knew earlier in which group they belong, so there might be subjective bias. So please remember, subjective bias is one of the very important issue in the randomized control trial. As a rule, what is the rule? Participants, they should not know in which group they belong. I'm telling you the solution later in the next slide. Next, there might be observer bias. Say for example, we have done one procedure where the participants are not aware in which group they belong. But say for example, I am the investigator, researcher, and I am collecting the data from each of them. Now I know which person they belong to which group. Now again, I might be biased, since I knew that yes, this person is received new drug. So I might ask, yes, how are you feeling now? He's telling, no sir, no good. No, you have got new drug, so you might feel better now compared to the earlier one. So I am biased. So I'm now making some error, introducing some error by asking the questions to the participants as well. So this is known as the observer bias. So what is the rule? Rule: observer or the data collector, the researcher, he or she, they should also know, they should not know in which group that particular person belongs, whether they are from the intervention group or they are from the control group. And third one is the bias in evaluation that cannot be controlled. So for to rule out this confusion, there is one procedure. This is known as blinding. This blinding is also known as masking, right? So blinding and masking, these are synonymous terms. So what is blinding? What is masking? What I told you earlier, that people should not know, participants, patients should not know in which group they belong. They should be blind. So this is known as the single blind trial. So when we tell single blind trial, that means the research participants, the patients of the trial, they are not aware in which group they belong. This is known as the single blind trial. What is double blind trial? Double blind trial means neither the participants nor the researcher, both of them, they are blind. They do not know in which group they belong. And third one is the triple blind trial. The participants, the observer, and person who is analyzing the data all are blind. So this is known as the triple blind trial. Ideally, triple blind trial is the ideal, but most commonly, whatever we do the double blind study. So is it clear? So by the single blind study, we reduce the observer, we reduce the participant subjective bias. By double blind study, we reduce the participant bias as well as the observer bias. So interviewer bias can be eliminated by the double blinding. Now, if you say no blinding is done in a trial, that trial is known as the open or open label trial. So sometime you might find one article that one trial dash, it is written as open label trial or open trial. What does it mean? It means that in this trial, no blinding, no masking was done. Clear? So again, one important thing is this. Now you have understood that blinding is good. Why blinding is good? Because blinding will reduce the observer bias and the bias of the researcher. But again, you see, blinding is only possible only for the drug trial. It is usually accomplished by the placebo. Say, for example, in one group, all the patients, I am giving one new drug, new molecule, but the other group, they will not receive any drug. But they will come to know, if I do not give any drug, they will come to know that yes, I did not receive the drug, that group received the drug. So what we do, we also give them one drug which is similar in looking, similar in consistency, taste, etc., size, and this thing. So what does it mean? This is known as the placebo. So in one group we give one drug, and in another group we also give one drug that is similar in looking. But in intervention group, the actual molecule is present, but in the other group, this is known as the placebo. No active ingredients of any drug is present. No drug is present, is only one just dummy. This is known as the placebo. Sometimes in some type of trial, blinding might not be possible. Where you see in one group, I will give one surgery. Then should you do the surgery or dummy surgery in the other group? Is it possible? Say for example, in some cancer patients, we have invented some new radiotherapy. Now we are giving radiotherapy, but in other group they will not get radiotherapy. Then how can you blind them? So these are the situations where blinding is not possible. Again, one term is used that is known as the sham treatment. What is sham treatment? When blinding is not possible, you see surgical intervention versus radiotherapy or injectable medicine versus oral medicine in two arms. You see, say for example, we are interested to investigate the effectiveness of new injection. So what I will do, the intervention group, they will receive the injection where there is active ingredient of the drug, and in the other group, they will also receive the injection, but the injection is a saline injection. So only saline water will be present. So no active molecule will be there. Right. So this is known as the SAM surgery. Again, this is a very big ethical issues. ICMR guideline is there in this situation. So you have to see the situation, and accordingly you have to proceed. So there are some terms are important in connection with the placebo. So what is in RCT? What is placebo? I have told you that is an inert treatment, which is similar to the active treatment. If you see the two strip of the drugs, you won't be able to differentiate its look, shape, consistency, color, and taste. Everything are same. But in placebo, it does not contain any active ingredients. So active molecule is absent in the placebo. Then what is the necessity of giving placebo? Helps in blinding. It helps in blinding. So participant, I have told you the protocol. The dictum is participants should be blind. The researcher, the observer, he should also be blind. So placebo helps in that way. One another term is there. This is known as the active placebo. What is that? What is that? You see, if you have taken some drugs like ofloxacin or nidazole, commonly used as O2 in some food poisoning in gastroenteritis cases, you see where ofloxacin is there is sometimes a presence of metallic taste and nausea. Now, suppose in one arm you are giving ofloxacin, and in another arm you have created one tablet that is looks same as ofloxacin. But patient will come to understand, yes, in that group the patients they are complaining of some side effects, but we don't have any side effects. So probably we are not getting the actual. So probably we are getting the placebo. So in that way, patient might become conscious. So to make them blind, to make them musk again, what is the option? The option is the active placebo. So same as placebo, it does not contain any active ingredient of a molecule, but it contains some things that mimics the side effects of the other drug. If anyone takes Avil or cetirizine, you see there is the sleepiness will be there. So same thing. So suppose in one group I am giving cetirizine or Avil chlorpheniramine, and in another group I am giving placebo, but there are some substances that causes sleepiness. So in that way patient will be made blind, right? So they won't be able to understand that they belong to the control group. Am I clear? So this is known as the active placebo. Next one is the double placebo. What is double placebo? In a trial of a tablet versus syrup, say for example my intention is to see for a particular disease whether tablet is good or syrup is good. Now if I give tablet in one group and in syrup in another group, then everybody will understand. So what is the option? Option is, you see, in one group I will give active tablet and placebo syrup in one group, and in second group placebo tablet, active syrup. So in that way you see all the participants of the two groups, they are now blind, they are now masked, and we can carry out our randomized control trial. Last, another one is the nocebo. What is nocebo? Nocebo is the induction or the worsening of the symptoms. So negative expectations of the patients.
It's not audible, sir. Sir is joining within 2 minutes again. There will be some network issue. Sir is joining again right now. Please wait for 2 to 3 minutes.
Am I audible?
Yes, sir. Yes, sir. Please,
Okay,
sir.
okay. Sorry. Actually, it got cut. So,
Okay.
did I cover this slide?
Yes, sir. Just covering in the middle.
Okay. It was in the middle now when I lost connection. Okay,
Yes.
no issue. Okay, no issue. Thank you. So you see what I've told you. I've explained you regarding the placebo. Now I have explained you the active placebo. Active placebo means same as placebo, but with some effects like sleepiness, nausea, and one term is there that is known as the double placebo. What is double placebo? Double placebo means my intention is to see whether tablet works good or syrup works good. Now if I give tablet in one group and syrup in other group, then the thing will be evident, the participants will not be masked. So what to do in this situation? We give active tablet and placebo syrup in one group, and that's just the reverse, placebo tablet and active syrup in the another group, right? So this is known as the double placebo. Next one is the nocebo. What is nocebo? It is the induction or the worsening of symptoms, so negative expectations of the patients, so induced by the SAM or active therapies. This is basically the nocebo. So we are intentionally worsening the symptoms, so negative expectation of the patients either by the SAM or active therapy. This is known as the nocebo. And you see, this is basically the structure of the randomized control trial. So this is the reference or target population. Say for example, my target population is the hypertensive population, those who are having high blood pressure. Now I have done one random sampling and I have taken the consent, and in that way I have chosen and random I have chosen the experimental or study population. Now from the experimental or study population, I have seen that some of them they are not fit to be included in my study. So in that way I have excluded some of them and I have included the rest of them. Now the rest of the patients, those who have included, so participant population, now you see, now I have done the randomization. So that is very important. Randomization should be done at the last stage when we are pretty sure, yes, this much of participants, they will certainly participate. So then we'll randomize into two groups. One is the intervention group and one is the control group. So in intervention group, the intervention will be given, and in control group, the control will be given, and the outcome will be seen after the certain period of time. Say for example, 6 months or 1 year, something like this, depending upon my objective, depending upon my the intervention strategies. And at the end, we will compare between the two groups. If I see that outcome is good in the intervention group, then certainly we can say yes, intervention did work good in this trial. Am I clear? So this is the structure. So how do we do the analysis in the randomized control trial? Analysis depends upon the outcome measurement of the variable. At first, baseline characteristics groups are compared, and we see whether the two groups are reasonably balanced or not. You see, whenever after randomization, we create two groups or three groups. Say for example, we have created two groups. Now we will see in the two groups the entire things are similar, same to each other, right? So how it has been possible? It has been possible because of the randomization. And there are two types of analysis. One is known as the ITT analysis, intention to treat analysis, right? So two approaches of analysis. One is the ITT analysis. You see, ITT means intention to treat. After I did randomization, my intention is to treat one group and my intention is it's to not to treat in other group. So accordingly I will analyze. But sometimes we see that some patients, they have left and they are lost to follow up, they are not coming. So in those situations some problem might be created. So please remember, subjects in ITT approach, subjects were analyzed according to their original allocation, so they are also known as the as randomized. So ITT analysis estimates effectiveness. So please remember, why effectiveness? Because my intention was to treat them as I have randomized, but since they are lost to follow up, some of them they are not coming, but we will include them in that group only. So this is known as the ITT approach. And second one is the per protocol approach. So per protocol means if a subject drops out or changes the treatment, then this is taken into account and they are no longer considered in that particular group. Just the reverse. In ITT approach, whatever they have left, they are not coming, they will still be considered in that group. This is the ITT. But in per protocol, what happens? Then subject drops out or changes the treatment, then they are no longer considered in the per protocol approach. So what is to be done? Per protocol or ITT? So please remember, ITT analysis is superior. and sometimes per protocol analysis is also done, right? And there are some limitations of the per protocol, so always you go for the ITT analysis. Now, how the exposure will be measured? When treatment outcome is measured, say for example, outcome measurement is dichotomous. Dichotomous means there is two outcome, right? So now you see, this is the thing. There are two groups. One A group is the intervention group, B group is the control group. Now we will create one table like this thing. So treatment outcome, success and failure. So in that way, I will see in which group the success is more. We will calculate A divided by A plus B and C divided by C plus D. We will calculate the percentage. If I see the success rate is more in intervention group, then we can say that this intervention has worked. If I see the success is more in control group, then I will say intervention group did not do well. So this is the percentage, and this absolute number we can calculate the Pearson's chi-square test. This is how we do this thing. So what is assumptions? The counted data, they will be mutually exclusive, and there are some assumptions of chi-square test. I'm not telling it here. So this is how we compare the RCT at the end when the outcome measures is dichotomous. Dichotomous means two possibilities, success, failure. So in one group, what is the proportion of success, and in control group, what is the proportion of success, and that can be statistically compared by the chi-square test. Now, there is also one analysis, this is known as number needed to treat. So impact of per protocol approach, what I told you, intention to treat approach. Second one is the per protocol approach. In per protocol approach, sometimes we want to see the impact. So that is why now the number NNT is now calculated. How NNT is calculated? It is calculated by this formula. So please remember 1 divided by PB by PA. What is PB? Say for example, two drugs are given in two arms. In one arm there is drug A, and in second arm there is drug B, and drug A is more effective than drug B, right? Then proportion of B minus proportion of A. So 1 by this thing is calculated, and whatever we say, if we see the NNT score is low, that means a more effective treatment. Clear? So two drugs A and B, A is superior drug, so we calculate 1 divided by proportion B minus PA. So low number needed to treat, it means a more effective treatment. This is how we interpret the NNT. Now, till now we were talking about the outcome when it was dichotomous, but now I will tell when the outcome measurement is continuous. Continuous means like this thing. Say for example, we are having two group A and group B. In group A, say for example, in this group I have given one new hypertension drug, and in group B there is old drug. And new group, at the beginning I have checked the mean blood pressure. In group B I have also measured the mean blood pressure. At the end I again the mean blood pressure, and at the end of the group B I will again measure the mean blood pressure. Now what kind of statistical test can be done? The last two means they can be compared by the unpaired t-test, and the first mean versus second mean of group A, this can be compared by the paired t-test, and mean of group B in the first and the mean of group B in the last, that also can be tested by the paired t-test, provided that the continuous data, they are normally distributed. But had it been so they are not normally distributed, then we will calculate the median, and Mann-Whitney test and Wilcoxon sign drag test will be calculated. So this is how the outcome measurement is continuous. Now you see, this is the thing. So two groups, group A and group B. In group A, at the beginning we have measured the mean, at the end again we will measure the mean. If the distribution is not continuous for continuous data, then instead of mean and standard deviation, we will calculate the median and IQR, interquartile range, right? So group A and group B. Now you see, This situation, first mean versus second mean, that can be tested by the pair t test. And median, and this, if had it been skewed distribution, it can be tested by the Wilcoxon matched pair test. And the two mean of group A versus mean of group B, that can be compared by the unpaired t test. So these are the different statistical tests. So similarly, that can also be done by the unpaired t test. So these are the different statistical tests that can be applied in the RCT whenever the outcome is continuous, right? So had it been median and IQR, then unpaired t test cannot be calculated. We calculate the Mann-Whitney U test. You don't have to remember the name of the test. These are all available in the book, but you just be clear about the conception, how do the different analysis and interpretation is done. Now you see, this is an outcome continuous. This is for the three group A, group B, group C. Here you see intervention was given. So at the beginning, mean was calculated, after 6 months, after another 6 months, after another 12 months, right? So if you calculate this one, mean 1 versus mean 2 versus mean 3 of a group A, then we call it as a repeated measure ANOVA. Now median versus median and median, this can be calculated by the Friedman's ANOVA. And this and the mean of group A versus mean of group B versus mean of group C can be calculated by the one-way ANOVA. Had it been not normally distributed, then one-way ANOVA will be replaced by the Kruskal-Wallis test. That is why I have written as the KW test. And when we are interested to measure the treatment effect, we can do the survival analysis. There are two types of survival analysis are there. One is the Kaplan-Meier survival analysis, and next one is the Cox proportional hazard model. Sometimes at the end of the randomized control trial, we also do the sensitivity analysis to check the robustness of the conclusion from the clinical trial. The different assumptions are there and different non-compliance protocol violence, these are also being assessed in the sensitivity analysis. So I've also taken some other slides. I will take another two minutes if you allow me. So one is the factorial trial. I've already told you, when more than one hypothesis is there and there is multi-arm. So you see, there are 4 different regime in 4 different groups. So 2 weeks this drug intravenously in first group, 2 weeks ECNP intravenously in second group, right? So in 4 different group, 4 different combinations are given. That is known as the factorial trial. I have already told you the crossover trial, right? Next is the cluster randomized trial. You see, there are some groups or clusters. These are randomized. The clusters are randomized instead of individual participants to intervention or control group. These are known as the cluster randomized trial. Most commonly used to evaluate non-drug interventions, like service delivery interventions or some educational programs or physical activity like this thing. So cluster randomized trial, so basically trial where some clusters we just include and this thing. And last, this is the last slide. So non-randomized control trial where we have control, but the controls, they have not been allocated by randomized manner. What I told you just now, randomized trial means both the controls and intervention group, they have been divided into 2 groups on the basis of randomization. But here, in spite of presence of 2 or more groups, the division was the allocation was not done due to randomization. So this is known as the non-randomized trial. So study on the seat belt legislation Australia, the control was in the other state. So this is one classical example of the non-randomized trial. I made some slides regarding the clinical trial. It will take another 2 or 3 minutes. Should I continue or I end? I've covered most of the intervention studies.
Yes, sir. Please, sir. Please, sir.
Okay. So I will not take much time. So next one is the clinical trial. Clinical trial is basically, in clinical trial, we see the safety and efficacy of a drug, right? So whenever new drug is developed, new vaccine is developed, it is undergone to two process. One is known as the preclinical trial, second one is known as the clinical trial. What is preclinical trial? From the name it is implied that preclinical trial is done in the laboratory. So clinical trial is broadly divided into two types. One, the preclinical trial, where it is done in the laboratory, and second one is the clinical trial proper. This clinical trial, there are basically four phases: phase 1, phase 2, phase 3, and phase 4. What is phase 1 trial? So this second point is very important. In phase 1 trial, it is usually carried on healthy human volunteers or certain types of patients. So as a general rule, as a dictum, phase 1 trial is not conducted upon patients. It is carried on upon healthy human volunteer. But say for example, I have developed one new anti-HIV drugs. I have developed one new drug that is for the tuberculosis, multi-drug resistant tuberculosis. In those situations, only phase 1 trial is conducted upon patients. Otherwise, the general rule is this thing, it is conducted upon healthy human volunteers. So this trial is also known as the first in man. Now in the phase 2 trial, same safety and efficacy of the drug is taken and it's conducted upon patients. So please remember, phase 2 trial, it is basically the new drug, the new vaccine that are applied on the patients. In phase 1, generally it is upon the healthy human volunteer, but in certain situation it is upon the patient. But when phase 2 trial, it is upon the patients. What is the justification? We here the dose and adverse reaction of the drugs, these are being evaluated in the phase 2 trial. In the phase 3 trial, it is also conducted upon the patients, but in the different subgroups, like children, like elderly, like patients having hepatorenal failure, patients having heart disease, patients having reduced lung capacity, etc., etc. So phase 3 trial in patient, but in different subgroups. So is it clear? So phase 1 basically healthy human volunteer, phase 2 is the patient, phase 3 is the patient, but in different subgroups. Now once a drug or vaccine has been cleared in the phase 3 trial, it has passed phase 3 trial, then it goes to the phase 4 trial. That is known as the post-marketing surveillance. Right. So phase 4 trial is basically the trial when the drug is available in the market. You and myself can go to the market and can buy the drug and can have the drug. So phase 4 trial is basically the post-marketing studies. So it is conducted upon general population. Clear? So that happened in 1961. One drug was introduced at that time, thalidomide, that was developed by one German company, and that drug was prescribed to the pregnant women, those who complained of insomnia, that is lack of sleep, and the patients. And it has seen that the mothers who took the drug thalidomide, most of them they delivered the babies. They are known as the phocomelia. You see the absence of the limb. So later on, the drug was withdrawn from the market. So this is all about the phase 4 trial. So whenever we'll do the trial, we have to go for the good clinical practice by maintaining the Declaration of Helsinki. With this few words, I thank you all for your patience hearing. So now I'd be happy if you have any questions so that I can answer to you.
Thank you very much, sir, for very informative and knowledgeable session. And now I would like to request our participants that please write your query in the chat box or raise your hand so I can send you the unmute request. Please. Dr. Sarayu Kore, please unmute yourself and ask your query. Dr. Sarayu.
Yeah, am I audible to you?
Yes, yes.
Yes, ma'am.
Okay, so it was very good presentation.
Thank you, ma'am.
Uh, I have to do some clinical trial of Ayurvedic intervention.
Right, ma'am.
with a control study. But then
Right, ma'am.
the control drug is modern drug because we want to study the efficacy. So we
Okay.
cannot have the same type of intervention, same type of placebo or the control study, no? So will it be okay for it? We
Ma'am, can you please repeat the question?
okay. I'll tell you. See,
Ma'am, please.
we want to try
Uh-huh.
try one drug which is incorporated in band-aid form. So can I use it is for fresh incised wound or lacerated wound? And so can I use a placebo for without the drug? The handy plast which is not having drug, only base cream, and another drug which is active drug. Can I take that? Whether it will be ethically okay?
Yes, yes. What I've understood, in one group you want to give one band-aid like this thing where some active drug is present, and in
Hmm.
other group same band-aid will give where active drug is absent. Am
Hmm.
I clear? So
Yeah,
yes, yes. That is the ideal thing. You
that
are
is
done.
ethical. But is it? But the another group will not get the good medicine available, best option. Then also is it good?
Ma'am,
It
see,
is okay.
Ma'am, see, what you can do, you can plan for a crossover trial like this thing. So whatever is this, you see, you have to see whether the new intervention is working or not. Now,
Yes.
now certainly you start with one group or you start with two groups. In one group,
Okay.
you give the intervention, right?
Hmm.
Now, after
Hmm.
6 months or after a certain period of time, whatever you have thought, you stop it and you see how many of them they have improved, and in other group, what is the output, right? Next, you
Hmm.
keep some gap, that is known as the washout period. So in
Yeah.
washout period, that all the drugs will be eliminated from the body. Now what you do, now you take the control group as an intervention group, and now the intervention group as a control group. So
Yes.
now you see the second group, they will now give the NICIP drug. So that is why ethically right. So
Yeah.
in some, so this is, you can do as a crossover trial like this thing, or you can per se do it as a normal randomized control trial, and you will tell to the ethics committee that if it is seen to be effective, then all the participants in the control group, they will also be offered, because the ethics principle, one of the thing is this, it is the justice. One of the important principles of ethics is the justice, right? So in that way, you are doing a justice as well. The other group, those who did not receive the drug earlier, now they will receive the drug. There is no issue problem.
No, but the it is a wound which will be healed by some say 15 days, 7 to 15 days period.
Okay, okay,
So I cannot go for crossover in this situation.
okay. No, then acha, only for 15 days. Then it's okay, na. So in 15 days you give this thing in the intervention
And
group.
we will be looking every 3 4 days. We will be the moment they are not happy, we can change the.
Right, right, right. Ma'am, what
We
what
can
what?
go for plain without any medication,
Okay, okay,
right? So
right.
I don't want to use betadine or something as a control for my drug. I want only the basic control. Then also it is okay, na?
Basic control means the, you see, ma'am,
Yeah,
one thing,
the
one thing.
vehicle of the drug in the band.
Ma'am, the thing is this, since it is a wound
Hmm.
and you are experimenting with a new ingredient,
Hmm.
now without this ingredient, one gold
Hmm.
standard treatment is there for the wound.
Yes.
Yes. So the control group, that control group will receive that one. And in
Which is
intervention,
available good standard drug.
yes, what is being practiced at the
Yeah.
present day. So
Okay.
in that way, you are not denying anybody to the present treatment,
Justice.
right? So justice is being there. So
Okay.
now the new the intervention group, they have received your band-aid,
Okay.
right? So after that, if you see this one, you can offer the same band-aid to the other group as well after the study, after 15 days or 20 days. That you can do.
No, but the wound will heal in the during that
Okay,
period.
okay. Then so there
So
is no
it's a
issue.
fresh wound.
Okay,
So
fresh ones.
can I take
So
like 7 days or after 7 days can I take crossover if required? If within 7 days both the wounds
yes,
are
yes, yes,
okay,
yes. Yes, yes, yes. Actually, yes, ma'am. That is actually the disease process on the progression of the disease process, duration of the process. That will
Yes.
usually dictate you the crossover time or the initial trial time. Yes,
Yeah.
that is correct.
Yeah. So after 50% relief, can I take crossover?
That you can take. Then you have to mention it in your protocol at the very beginning. We will
Yeah.
do this thing, and whenever we will see the 50% has it, we will cross them over. Or you can say like this thing, let it be like this thing. You see, you are not doing, you are also doing justice to other group by providing the standard treatment what is available as on today.
Right.
But in the intervention group, you are giving something new.
Yeah.
Right. So in that way, you are not doing any injustice. Now,
But
if
this
it is,
new is having evidence from Ayurvedic Samhitas, no?
uh,
This is the established drug of uh, Ayurvedic Samhita has been recommended. Only I am changing the dosage form.
okay, only the dosage form. Okay, then it's okay. Suppose I'm telling you in your
Hmm.
intervention you are giving 50 milligram dosage. I'm telling you, and in the
Hmm.
control group that is the usual is the 20 milligram dosage. That you also can do. You offer the treatment in 20 milligram dosage control, and you are giving higher dosage 50 milligram in the intervention group. Then so there is no issue. You
Okay, so
complete the
little
treatment.
less and more.
But ma'am,
Okay, this is also good idea.
this is also good. But the thing is this, ma'am, you have to be very pretty sure that you are not denying anybody
Yes.
the present treatment options. The
Yes.
present treatment option is there, but we are
Yes.
we are giving old or some previous treatment protocol. That should not be done.
Yes. Yes. Okay. Thank you very much for
Thank you.
giving multiple options.
Thank you. Thank you.
As ethical committee will approve the protocol, I can go ahead with it.
Yes, yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you, sir. Thank
Thank
you
you.
very much.
Thank you. Most welcome. Any
And
other question?
Dr. Rahul Gujarati. Dr. Rahul.
Huh.
Good evening.
Good evening.
Sir, you're not audible.
In the
Dr. Rahul. Yes.
Sir, I cannot hear actually.
Your voice is not, you're not audible, Dr. Rahul. Please try again. Dr. Dija. Dr. Dija, please unmute.
Yes, yes, yes.
Yes, yes, yes.
Hello, sir.
Audible. Hello. Yes, please. Please tell
Hello,
me.
sir. I'm Dr.
Yes.
Dija, sir. Yeah.
Okay.
Okay, sir. My doubt is in your slides you told that without control, that is pre-post test, there we have to use the chi-square test. Hello.
Yes,
Dr.
yes.
Rahul, please wait. Please wait.
So whether in such cases whether we can use the Z test or the paired T test and all.
See, very good question, ma'am. Very good question. What I told you, maximum, I have showed you one group before
Yes.
and after.
I have a very issue. Is that
Dr.
is
Rahul,
it
Dr.
fine to the
Rahul,
placebo in RC?
Dr. Rahul, please wait.
Hello? Hello?
Dr.
Dr.
Rahul,
Rahul,
not
please
audible?
wait. Please wait.
Okay, am I audible
Yes, please wait. Yes,
now?
please wait. Please
Dr.
wait.
Rahul,
Dr. Rahul,
Dr.
please
Rahul,
wait.
I am just answering another question, then I will come to your question, right? So what you have asked that in without control group, suppose one group is present, then I have given one intervention, and
Yes.
after that I am taking the outcome of the same group. So no control
Yes.
group is there.
Yes.
So in this situation, two types of tests can be done. If your
Yes.
outcome is dichotomous, say for example, anxiety present or absent,
Hmm.
before intervention, after intervention, then the choice is McNamara chi-square test. I've told you.
Okay. Okay.
Now,
Okay.
now, if your outcome is continuous variable, say for example, you have taken one group, you have given new drug of to reduce the sugar. Previously, you measured the sugar of the group. You have calculated the mean sugar. Now,
Hmm.
after intervention, you have also calculated the mean blood sugar again of the same group.
Hmm.
If the blood sugar distribution is normally distributed, then surely you can go for paired t-test as well.
Okay.
You're
Then
absolutely correct.
okay, sir, one more thing. They're also in pair T test and the Z test that will be varied depending upon the number of participants, right?
Exactly, exactly. You see, ma'am, then you have to see the pair t-test or t-test is classically said that when the number of participant is less than 30,
Yes, yes.
and z-test is done when the participant is more than 30. But again, I am
Okay.
telling you, this is the classical book teaching, but you can go for a t-test even with higher sample as well, provided
Oh,
provided the assumptions are made. You have to go through the assumptions of the t-test. The basic assumption
okay.
of t-test is this thing, that the distribution should be normal.
Okay,
Distribution should
okay.
be normal, right? So if you see before intervention, you see the two distribution should be normal. Before intervention, the distribution of blood sugar, it is normal. After intervention, the distribution of blood sugar is normal. If both the two groups are normal, then only you can go for the pair t test. Had it been that one group is not normal, one group is skewed, then you cannot go for the pair t test. Then the non-parametric counterpart of the pair t test, that is the Wilcoxon sign rank test, that is to be done.
Okay, okay, okay. Okay, sir. Thank you.
Thank you. Most welcome. Most welcome. Dr. Rahul, please come.
Dr. Rahul, please unmute yourself. Dr. Rahul, I think there is a network issue at your end. We are unable to hear you properly.
In
Not audible, sir. Dr. Nakul,
Good evening, sir. Good evening, sir. Am I audible?
yes, 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 you are audible.
My question is how to know which is gold standard drug and what is the criteria for gold standard drug in comparative studies, sir? Am I
Dr. Rahul, please rejoin the session. We are not hearing you properly.
You see the last question. Oh,
1 minute.
what is the how to know which is hello?
see how to know which drug is gold standard. It will only come from the literature review. So you have to go through the review of literature. From the review of literature, they will say that yes, this drug is gold standard, right? From your RCT, you cannot establish that it is a gold standard. You have to see the review of literature, which drug is gold standard for that particular disease, and that has to be taken as gold standard. And against the gold standard, you are giving some new drug that you can add as the intervention group. Am I clear?
Yes, thank you, sir.
Thank you.
Is there any more query? Please raise your hand. Dr. Shruti, the last query from Dr. Shruti.
Am I audible, sir?
Yes, yes, perfectly audible. Please carry on.
Namaste, sir. Session was very well explained. Very nice session, sir. Sir,
Thank
I
you.
have a query. Sir, if we are doing single group interventional study, which is without control, so is there any chances of bias? If yes, then how we can correct it? Means there is no randomization.
See, this is also one type of experimental study without control group. I have told you.
Yes.
Now, in this situation, both the observer, both the investigator, they were aware that in which group they belong, right? So in that way, that bias will be there. The basic issue of randomized control trial, that we are making it 2 or 3 groups, and by using some techniques that is known as blinding or masking, we are creating something so that the participants and the investigator, they remain unaware of the facts that in which group they belong. This is the basic intention. Now, if there is no control group, say for example, I have taken in one group and I am giving them intervention, so all the participants, they know yes, I'm getting the intervention, and as a researcher, as I'm collecting the data, I also know yes, they are receiving this thing. at the end. So, right, so that the two important biases what I have told you in my slide, that is the participant bias and the bias of the researcher, that you cannot avoid in here, isn't it?
Sir, you have already explained about the anxiety case, no? Sir,
Right.
same way, if we are using non-medicinal intervention, in that case, what we have to do? We can
Non,
go for that study with single group without control.
yes, but you see, you obviously can go a single group without control, but this is somehow inferior. The superior is
Okay.
with control. Because from our conversation you have understood that
Yes,
some
sir.
type of bias, it is inevitable without control group. You cannot eliminate, isn't it? You
Sir,
cannot eliminate.
uh, no, sir, I just want to ask you, ki if we are giving or we are in group, that interventional group, we are giving asanas for practicing asanas. So only one group is sufficient. Na? We are studying those subjects before and after studying.
You see, you can do as a researcher, you can do, but as I have told you, without control is somehow inferior compared to with control study. Had it been
Okay.
your studies with control group, that would have been much more robust,
Okay.
much
Okay.
more strengthened, much
Okay.
more
Okay.
contribute in the scientific community.
Okay. Thank you so much, sir.
Thank you, thank you. Next question.
Dr. Rahul written his question in chat box. In RCT, it is ethical to give a placebo to a group and depriving him of the treatment.
I have already discussed the issues what Dr.
Yes.
Rahul has asked. I've already discussed. You see, what the question is very important, that should we deny? Should we not give the opportunity to have them the new drug? Yes, we should give them the opportunity. But since it is a research is going on, but at the end, we also do some type of trial. We do some counseling session, those who are having tobacco smoking or alcohol users. In one group we give some special counseling, and one group we do not give, we give the standard one. But if I see that it is found to be beneficial, then at the end of the study we should offer the same counseling to the control group as well, so that at the end, you see, my research does not end that when, yes, my data collection is over, okay, now I'm going in my lab, in my hospital, in my research center. No, it will still continue. So in that way, you should provide the opportunity to have them as well. So in that way, you can maintain the justice to the study participants. Next question.
Dr. Umesh.
Namaskar, sir.
Namaskar.
Sir, my question is that in case control study, which is having two group, one is disease or trial group, and second is related to the healthy group. What kind of statistical analysis should be done in the last for result interpretation?
Right. So this is a session of intervention trial, and you have asked a question of case control study. In case control study, you are very much correct that one group is the diseased, that is the case. The other group is the control, those who are not diseased. In case control study, basically we see the same table what I showed you in the RCT, that is in cases and in control, exposure plus exposure minus. So among the cases, what is the exposure? Among the cases, what is the non-exposure? So we calculate the proportion and we compute by the Pearson chi-square test. In addition, we calculate the odds ratio. So please remember, in chi-square, in case control study, we can do Pearson's chi-square test plus odds ratio. And if you
Thank
want
you,
to
sir.
and if you want to do some advanced statistical analysis, then another statistical analysis can be done, that is known as the conditional logistic analysis, regression analysis can be done in case control study. So you write it down, you later go ahead with this thing.
Conditional, please repeat.
Conditional logistic regression analysis.
Okay. Thank you, sir.
Thank you, most welcome. Thank you. Next.
I hope all queries are answered. If there is any remaining query, then you can mail us. I have provided one mail ID. And on Monday, we have one more session with sir, and be ready for that. Now, I would like to request our chairperson, Professor Satya Manodayal Sharma, who is a principal and HOD at Swasthya and Yoga in the Department of Swasthya and Yoga in Uttaranchal Ayurvedic College, Dehradun, to kindly share his views and experience and kindly sum up today's session. Please, sir, welcome, sir.
Thank you, sir. Thank you. And sir, your lecture is very enlightening, and it is almost about all types of designs and uh, uh, negative and positive control groups and single and double blind groups and about clinical trial. And I am very thankful for
Thank you,
you.
sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you.
Thank you very much, sir, for your presence and sharing your experience with the participants. Now, this is the end of today's session. We again meet on Monday with
Monday.
one more session with sir, Dr. Indranil Saha sir, and session is hybrid district design and its measure.
Right.
Now, from the Joint State Training Center of Rajasthan, we convey our sincere thanks to all the participants for their active participation and commitment for today's session. We heartily thanks the guest speaker of the session, Dr. Indranil Saha sir, who kept participants engaged by the way of very informative and interactive session. We also thanks Dr. Satya Manodayal Sharma sir for chairing today's session and sharing his experience and view about the session with the participants. Now this is the end of the session. We again thanks to all of you. Again we meet on Monday at 6 p.m. sharp. Thank you again. Thank you everyone.
Thank you.
Sir.
Thank you.
Thank you sir. Thank you Lalin sir. Thank you Satya Manodayal sir.
Thank you. Thank you.